Good evening, everyone. First of all, I would like to thank you very much for attending our event today. And I would like to express our gratitude to Mass General and Brigham hospitals for being a partner in this event and presenting today. It is such an honor for Vie to finally find more like an association and partnership in a place where we can send our patient to for the ultimate care. So we are so pleased to do that, and it is really we're honored to be part of this as well. So allow me for this evening to welcome Dr. Ephraim Hochberg. Dr. Hochberg, by the way, this is a very, very short summary about Dr. Hochberg. It's like, when I looked him up and started reading about him, it's, but anyway. So Dr. Hochberg is a board certified in medical oncology. He holds a fellowship in hematology and oncology. He spent most of his training at Harvard Medical School, the best medical school in the world. Dr. Hochberg is the Deputy Medical Director at Mass General Brigham Cancer Center. He is also an assistant professor of medicine at Harvard Medical School. Dr. Hochberg is at the forefront of cancer prevention and treatment. Today, he will share insights on cutting-edge cancer screening and innovative treatments that are shaping the future of healthcare. Please welcome Dr. Hochberg with me. Thank you very much. Thank you.
Thank you all very much. I get very embarrassed by introductions. So I'm going to try to, over the next hour or so, tell you who we are as a system, talk to you a bit about our vision of cancer prevention, cancer early detection, and I want to teach you a little bit around how we are thinking about the future of cancer care. At the end, I want to talk a bit about how we think about taking care of patients who have been diagnosed with cancer and give you a sad example that I think will exemplify the way in which we think about ensuring that every patient gets holistic, personal, tailored care. What was very interesting to me over the last 2 days of working with the Vie team is getting that same sense reflected from the way in which they think about primary care and ensuring that you have access to primary care that's preventive and thoughtful. It's not reactive. You don't feel sick and then you go. You have a team of physicians who are looking after you and looking toward the future, taking a healthy person and keeping them healthy. So these are the 4 things I'll talk about. I'll talk about Mass General Brigham, who we are and what our clinical programs are. And then I'll spend most of the time talking about Mass General Brigham cancer care. And I'll talk specifically about our Center for Early Cancer Detection. And at the end, I'll comment on our multidisciplinary care. So Mass General Brigham is sort of a new entity. What we are is we are the merger of a number of large teaching hospitals, the Mass General Hospital, Brigham and Women's Hospital, and some others. In all, we see about 1.5 million patients a year. We have about 78,000 employees. The third line is what we are most proud of, is that together we are the largest cancer-based research center in the world. We get about $2 billion from NIH, from the NCI, to fund our research efforts. And we view this concept of research-infused, thoughtful patient care at the core of what we do. We have 450 research and clinical departments, and we have about 6,200 faculty of Harvard Medical School. The way Harvard Medical School works is a little unusual. It's one of the few medical schools that doesn't actually have a single hospital attached to it. It has a group of hospitals, and almost all of those hospitals, with 2 exceptions, are part of our system. So Mass General Hospital is where I work. This is a 1,000-bed hospital in the center of Boston. It's the 3rd oldest hospital in the U.S., and we are consistently ranked as one of America's top hospitals. We are proud of the people who take care of our patients, and in 3 years, when our new building is built, we will be as equally proud of the space in which we care for them. We are still seeing patients and doing work. not actually seeing patients, but there are some scientific labs in a building from 1811, which is very historic and very pretty, but not exactly a patient-centered environment. But our physicians are absolutely top-notch, and our diagnostic equipment is absolutely state-of-the-art. And soon we will have a beautiful 2 million square foot building to match. Our sister hospital, Brigham and Women's Hospital, is a world-renowned obstetrics and gynecology institution, as well as a world-class cardiology hospital, but also contains experts across every field of medicine. It's actually, it's the closest hospital to Harvard Medical School. It's directly attached by this long corridor. When we put together the system, we recognized that patients have all sorts of different needs. And one of the needs that was consistently under-addressed is the ability to take a patient who's become sick from whatever the process is and return them to health. And that process of rehabilitation shouldn't be random or an afterthought. An academic effort focused on rehabilitation at the absolute acme of rehabilitation science, and that defines Spaulding Rehab Hospital. I was telling the team that I saw an amazing presentation by one of their rehab neuroscientists, and he has a system where he puts electrodes into the brains of people who cannot speak, who've lost the ability to speak. And he showed a video for the first time of a patient who had not been able to speak for 6 months, and the electrical impulses of the idea of speaking in the patient's brain were translated into speech. And this patient could talk to their daughter for the first time in 6 months. And for me, I used to think of rehab as, people stretching your arms and legs, but it's really more than that. And Spaulding is the absolute forefront of that field. Another member of our system is McLean Hospital. This is the either the first or the second best psychiatry hospital in the United States. Every year, McLean changes place with Mass General, which also has an extraordinary psychiatry department, but it has a wide range of psychiatric and psychological support services across every field of cognitive and mental disorders. Finally, the last core member of our group is Mass Eye and Ear Infirmary, and this is a hospital that focuses on eye, ear, nose, and throat illnesses, and they have world-class surgeons. Our relationship with Harvard Medical School I talked about a bit previously, but one of the things I wanted to point out is that when you think about someone being a member of the Harvard Medical School faculty, there are people they're talking about are physicians. And it's our privilege of working at these hospitals to be on the staff of Harvard Medical School and to help train extraordinary medical students, residents, fellows, and senior trainees across every conceivable field of medicine. This is our CEO's statement about our vision, which is Mass General Brigham's vision is to build the integrated academic healthcare system of the future with patients at the center, transforming care, not taking the past for granted, but trying to look forward, trying to generate advances across every field of medical science, improving outcomes and expanding our impact locally, nationally, and globally. So my other job is I'm the medical director of international patient services for the hospital, in addition to my operational role within the cancer center. So I'm here speaking with you today, trying to build our awareness of this new entity that comprises these 5 extremely distinguished hospitals. So I want to talk a bit about 8 centers of excellence that we have, and then I'll get into the meat of the discussion around the Cancer Center. So the Cancer Center is on the top left, and we're particularly proud of a couple of different things. The first of these is our Proton Therapy Center. When you think about radiation therapy, most of the time radiation therapy is a beam, like a beam of light, but much more powerful that can pass all the way through a patient, which is great for treating cancer. The problem with radiation therapy is that the beam passes all the way through. And if you have a tumor on your mouth or in your tongue or in your face, and you don't want that beam of radiation to go all the way through into the brain, you need something different. And that's what proton radiotherapy offers. You can tell a proton, through some physics I do not understand, to stop. You can say, listen, go 2 centimeters and then just stop. And that's what protons can do. And it takes a very large piece of equipment to do that. And we've had that Proton Therapy Center for about 35 years. We were the second facility in the world. And now we have 2 proton therapy accelerators. And for specific kinds of cancer, it's a major advance. The second thing I want to talk about is CAR T-cell therapy. When we think about cancer and we think about cancer treatment, historically, we've had 3 ways of treating cancer: chemotherapy, surgery, and radiation. And within chemotherapy, there have been some subtleties around immune treatment and targeted therapies. But for the first time, what CAR T-cell therapy does is it gives us a fundamentally different way of fighting cancer. And the way it works is as follows. We think from a biological point of view that everybody gets cancer. Everybody has a mutation in their body, and that mutation appears. But in most of us, our immune system recognizes that group of cells that have the cancer and kills them off. And that person have cancer, and then the cancer is gone. In the people who develop a cancer that grows and divides and becomes symptomatic, the immune system has somehow been bypassed. What CAR T-cell therapy does is it's a technology that allows you to take an immune cell from a patient, a normal immune cell that might be fighting tetanus, take the immune cell out, genetically program it to recognize the cancer, grow it up, and then infuse it back into the patient. And when you do that, the immune system gets a whole second chance to fight the cancer. This has been incredibly effective in lymphomas, leukemias, multiple myeloma, and now is beginning to become effective in other tumors as well. So we're very proud that we led a world-leading trial on using CAR T-cells to treat patients with relapsed brain tumors. And we've shown that by injecting these immune cells right into the brain, you can cause brain tumors to shrink and maybe even cure patients. We've also done a lot of work, which you'll talk about in a bit, on finding cancers earlier and finding out which treatments are useful, and that's our circulating tumor cell and genetics group. I know much less, because I'm not a cardiologist, about the other areas of our specialization, but we have world-leading cardiologists in a couple of areas. We're particularly focused on patients with very end-stage heart failure and designing assist devices and machines that can replace some of the function of the heart. That's the HeartMate 3 trial. We have a very large nationally recognized orthopedics unit. We are the orthopedic physicians for most of Boston's extraordinary sports teams. I recognize there's extraordinary Canadian sports teams as well, but we also have very good sports teams in Boston. And we have superb orthopedic surgeons across every area of orthopedics. We have a particular pride in our neuroscience group. So across our hospitals, we have over 500 neurologists specializing in every area of neurology. I think this is a really important point around the way that we think about our cancer center. We are not a standalone cancer hospital. We are not MD Anderson. We're not Memorial Sloan Kettering. And one of the reasons that we think there's something different about having a cancer center embedded in a general hospital is the following. There are probably 15 neurologists who work at MD Anderson, the largest cancer hospital in the world. There are 15 neurologists at Mass General who just do Parkinson's disease. And there's 15 who do Alzheimer's, and there's 15 who do ALS, and there's 15 who do movement disorders, and every conceivable field of neurology. If you have a problem that is cancer and something else, and you want world-class expertise in the and something else, that's a place where the kind of services we offer are really differentiated. A couple other areas. We don't just focus on the edges of medicine and scientific advances. We're extremely proud of our palliative care and geriatric medicine programs, which are trying to ensure that people can live life to their fullest at every age and with every stage of illness. We have a very strong pulmonary and critical care unit focused on a number of areas of pulmonary medicine, as well as a long COVID clinic, which has unfortunately gotten busier. We have a pediatrics hospital, which takes advantage of the resources of all the medical advances to provide those same benefits to children. And we have a globally renowned disaster medicine group, which does both national training as well as deploys teams. I want to spend most of the time talking about the things I actually know something about, which is the Cancer Center. This is a really complicated eye chart, but the concept behind this is we've spent about a year thinking about what it means to be a patient with cancer. What are all the ways in which patients with cancer touch our system? And how can we think about improving the care in every one of these dots? This starts with community outreach in the concept of prevention. How do you work up cancer efficiently? What are the best available treatments? How do you manage survivorship and ensure that patients don't suffer long-term consequences of the treatments they've received? And in unfortunate circumstances, how do you make sure that the end of life of a patient is as healthy and full of meaning as possible? So I'm going to talk about 2 of these 35 bullets, the Center for Early Cancer Detection and our multidisciplinary care. But I could, with a little effort, do the same presentation on any of the other topics as well. So Center for Early Cancer Detection. This is our center. It's in Waltham, Massachusetts, a little bit outside the main hospital. It's a beautiful new building and really an elegant physical, not as nice as your spaces, but it's very nice. So I want to start with a pretty simple concept, and I want to focus on this concept because this is the heart of why we are doing this work. If you think about the cancers for which we have screening, lung cancer, colon cancer, breast cancer, and you detect a cancer at a limited stage when it's still contained within a single area of the body, the cure rate is very good. That exact same cancer, if it's spread to other areas in the body, has a much lower cure rate. A colon cancer that's localized might have a 90% cure rate. A colon cancer that's metastatic has a very low cure rate. Only in patients where that metastasis or that spread is in a single point in the body can those patients be cured. This is equally as true for cancers that we have no screening for. If you have pancreatic cancer and you happen to catch it early because you have an ultrasound or something else done as prevention, your chance of being cured is 80% in really good surgical hands. If that pancreatic cancer is spread, almost no one is cured. So when you take that concept of early detection and you recognize that early stage cancers have a much better cure rate, it compels us to begin to ask the question, why are we not doing such a good job? So this is actual data from the United States, from this epidemiologic registry where all the cancers in the US are kind of about 60% are aggregated into this big data source. And you can see across all of these common cancers, the only thing you need to see on here is that the blue line is higher than the purple, is higher than the gray. And that's local disease, disease that's spread in the immediate area, and then disease that's metastatic. And the survival is significantly better. There are other ways of looking at this. If you look just at breast cancer and you look at countries that have the ability to do screening, Canada, America, high-income countries, the overall survival in breast cancer is 90% in those high-functioning countries. If you look at countries that have less screening, India, it's about 60%. If you look in South Africa, it's about 40%. If you have screening programs in place, the survival is improved. There's another point that's equally as important. It's that we don't have screening tests for all cancers. I made that point around pancreatic cancer before, but that circle on the bottom right, the red, is 79% of cancer deaths are in cancers we cannot screen for. So we don't know how to screen effectively for pancreatic cancer. We don't know how to screen effectively for ovarian cancer, although there's some dispute there. And 79% of deaths are in things we can't screen for. You could make the counter argument. You could say, listen, that 21% of deaths in cancers we can screen for, that would have been 50% if we didn't have all those screening programs. And I guess I'm more looking at the future than looking at the successes we've had previously as oncologists. But we have to do better. So this is what the U.S. Preventive Services Task Force recommends, and this is the kinds of things that Vie makes sure that you guys are all up to date with. Breast cancer, mammography screening, colon cancer, colonoscopy screening, lung cancer. If you smoked for 20 years, a pack a day, you should be getting a low-dose screening CT scan every year to look for early lung cancers. Cervical cancer screening as well. So how do we think about putting this together? What does the future look like? Those recommendations I showed you are for the entire population, but all of you in this room are not equal. You vary widely in age, in what you've been exposed to. How do we think about not having screening be monolithic? Everyone gets the same screening, but instead we're a little more thoughtful, we're proactive, we identify subgroups of individuals who ought to have different screening. So the idea is if you take an entire population, all here in gray, you can begin to think about separating those people with risk assessment into groups. Some people will be very high risk in red, a few people, very strong cancer family histories, or they have a genetic mutation. High risk in pink, intermediate risk in purple, and low risk in blue. And then in a future state, you can think about a world in which people at the very lowest risk maybe don't have to do quite so many of these extremely annoying colonoscopies. And people who are very high risk, who have a very high risk of colon cancer, maybe they need it every year, or they need it much more frequently. Or people who are very high risk for breast cancer should think about seeing a surgeon for a mastectomy before they get a breast cancer. So we think the future looks much more like this individualized risk assessment, where you take these national guidelines and you think carefully about individuals and what their personal risks are. Okay, so what are the personal risks? There's a couple we can't change, and the biggest one is age. This is the risk of cancer per every 5 years of life, and it goes up and up and up. At the very top, maybe there's a little decline. There's something special about a very small group of people who are very old. They don't get cancer. But in general, that's a very strong risk factor. So the second thing you can't change is your genetics. We're born with our genes, and with very rare exceptions, we don't have a way of fixing that. If you have a gene, if you have the BRCA1 gene for breast cancer, you have between a 40 and 60% lifetime chance of getting breast cancer. That's a huge risk. And the same is true for a whole number of other genes. And those are things you can't fix. The good news is there are things you can fix. And this is the risk of cancer from lifestyle choices that people make. The big red box here has a cigarette at the top of it, in case anyone was unaware of what one of the largest risk factors for cancer is. It's smoking. And smoking, we think, accounts for about 20% of modifiable cancer risk. The second has a little scale. That's being overweight or weighing too much. I just saw a statistic that I think 76% of US adults are either overweight or obese, which is a terrifying statistic. I'm not sure what the Canadian number is. The black bar is alcohol. Excessive alcohol consumption is a significant risk. The yellow is infectious processes. The green is overeating. The blue is exposures. And the black is being a sedentary lifestyle. So there are significant components to the way in which we live our lives that add to our risk and that help us build that matrix of which risk category we fall into. The last is occupational. On the far right is a picture of a London child chimney sweep in the 1900s. And it was a terrible profession, not just because it was a terrible thing to do to children, but it was also terrible because of the risk of cancer. And all that exposure to the soot generated enormously high risk of both skin cancers as well as lung cancers in those children. But people who are exposed to pollutants in those industries have a risk. The same thing is true about firefighters. So firefighters have a significant occupational risk, and there's some data that military soldiers do as well. In the US, exposure to depleted uranium or chemicals do increase the risk. So what are we doing about this? And what we're doing is we're trying to get the best data we can, not only looking at the risk factors that an individual knows about, but taking the data that we have and trying to use it to generate better risk estimates. So this is a AI-based image detection program we've been running called Sybil. And we took 45,000 of the CT scans that are done on patients who've smoked for 20 years, and we ran them through a system to try to identify not the ones with the obvious cancers, but the people who were going to develop cancer based on subtle things that the radiologist couldn't see, but the AI could begin to pick up. This is a process that we're beginning to roll out, and we have active clinical trials where patients are enrolled on regular CT scans or CT scans with this AI augmentation. The idea being that we can do a better job at using the testing that's already being collected and get more information about a patient's individual risk. The next way in which we're trying to do this work is using these novel cancer screening tests. And this, I think, is one of the next significant advances in cancer early detection. I have an analogy for this test, which is that it's a little bit like 100 years ago when cars replaced horses. At that point, it wasn't really clear that this loud, clanking, horseless carriage was going to be all that much better than the lovely horse that would chew some grass and take you back and forth to town. And this is the horseless carriage version of this test. It's the very first one that's been released. And I'm going to tell you, it comes with its bumps and its flaws, but it represents a little peek into what the future of cancer detection will be. I believe in it. I think this is the first step on the path to the future, but it's not the Tesla. It's not the silent, beautiful car that you can drive now. So the way this works is as follows. And you have to understand a little bit about cancer to appreciate how this test functions. When cancer develops, one cell in the body has a mutation. Something goes wrong with the DNA of that cell. And that change in the DNA does one of two things. It either makes that cell not die, or it makes that cell grow more quickly, or sometimes both. And over time, that one cell becomes 2, 4, 8, 16, 32, 64. Then it begins to spread at some point to other parts of the body. What's important is that there are changes in the DNA. That is not a normal cell. And sometimes the little pieces of DNA that are different from all the other normal DNA spill into the blood. And these little fragments of DNA are detectable in the blood. So the way this test works, a patient gets a blood draw, same as any other blood draw, and the blood draw is run through a complicated algorithm by a company, and that algorithm gives you one of two results. Either there is a cancer signal or there is no cancer signal. Then it does something else. It says, if there is a cancer signal, where might that cancer be coming from? You get a blood test and you get a signal, and the signal says, we're worried about cancer, and we're worried specifically about colorectal cancer. And that's the signal, that's the mutation profile that was seen. So what happens then? Well, that's also really a terrifying thing to have happen. So the way that we've constructed our center is that when that blood test comes back, we have extremely rapid access to colonoscopy and to a PET scan to ensure that you're not left hanging in suspense with this, you might have cancer, now go figure out what's going to happen to you. But instead that signal is rapidly translated into action. And the answer is different for each of the things on this list. If the concern is for kidney cancer, you get a CT scan. If the concern is for head and neck cancer, you get a surgeon to look into your mouth and throat and make sure that there's no lesions in your head and neck. But it's the beginning of the steps forward in the way that we think about cancer detection. So this is how good the test is. And I'm going to talk to you about these numbers, and no one likes statistics, especially late in the evening, but I'm not going to give you very much statistics. I'm going to try to give you what this practically means. So about 1 in 100 people who get the test are told that there's a cancer signal detected. We can only find a cancer or something that we think was generating that signal in about 43% of those people. So 1,000 people get the test, 10 are told there's a cancer signal, and 4 of them we can find the cancer. I don't know about the other 6. Is it that the test isn't right? Maybe the cancer is too small to find? Do they need to be scanned again? So there's a lot of uncertainty. This is the very first version of this kind of assay, and there are problems with it, but it's a step in the direction of the future. The most important reasons why I think it's a step in the direction of the future, I'm just going to point to 2 things on this slide. This one and this one. So this is a pancreas cancer that was detected and a small intestinal cancer. Those are 2 of the cancers on that figure I showed you of things we cannot screen for. And 67% of the cancers that were found were in stage 1 through 3, local or locally advanced. 38% were just localized. So this is our little glimmer into the future of a time when we will get this blood test, and these cancers that we have no screening for, that account for 79% of cancer deaths in the US, will have an effective screening process. This test is here now. It's the best thing that's available, although other things are being worked on. But it's not a perfect test by any means. Does that make sense? So our vision for the center is we want to develop this center that's focused on decreasing cancer mortality and morbidity by diagnosing, testing, and implementing early cancer detection. We wanted to build a center where we could ask the questions around who are the right patients to get this test? Who are the patients who should get a different test that's being studied? If there are other companies doing clinical trials on the second and third and fourth generation of these tests, where can they come to make sure that that work is done? And if a patient wants to be screened for cancer, what's the place in our system where they can come to? The test is somewhat available in the US. You can go to a primary care doctor and order it. The problem with that is when the primary care doctor gets a result back saying pancreatic cancer, they're not embedded in a cancer center. It's very hard for them to get you into a world-class pancreas surgeon very quickly. So we think there's an advantage to doing this in the context of the cancer center. The second thing that we wanted to build in is a recognition that what we've talked about so far is screening for cancer on the left-hand side here. The other piece of work we have to do is if someone comes in and they say, listen, I'm coughing up blood, or I feel a lump in my neck, or my voice has been hoarse and it's getting more and more hoarse over 6 months, I'm worried I might have cancer. What happens in the US is that your primary care doc sees you, maybe if you have a good primary care doc, and here you do, and they ensure you that, well, it's probably nothing, let's take some antibiotics and see how you do. And if you push them, they say, okay, well, I'll put you on the list for a colonoscopy, or I think I know a surgeon who will feel that lump in your neck and figure out what it is. And we wanted a place where our system could refer patients who we think had cancer, where we are people who had expertise in that. We had surgeons on staff, we had interventional radiologists, and we could do the workup in one place quickly and efficiently. And the reason for that is that we recognize that delays in cancer treatment are caused by all sorts of things. But one of the biggest ones is access delays in getting access to the teams that you need to see a patient quickly, the right specialists in one place to ensure that cancer is diagnosed as quickly as possible. And that delays in treatment don't cause the stage of the cancer to go up and therefore the cure rate to go down. So we thought these two centers fit together nicely. The early detection for people who don't have cancer and the diagnostic clinic for people who have a suspicion of cancer. And we've seen about 2,700 patients across the center at this point. And we've seen a lot, unfortunately, of new cancers diagnosed. But we'd like to think that by having them come through the center, those cancers have been diagnosed earlier than they would through the routine course of events. So the two pieces are cancer risk assessment. What's the personalized assessment of your cancer risk? What are the recommendations and what new screening methodologies are we working on? And then people with a suspicion of cancer, rapid diagnostic workup of abnormalities or things seen on x-rays that might suggest cancer. These are our two leaders. Leisha Sequist is a professor at Harvard Medical School who clinically specializes in lung cancer. And Doug Michelizzi specializes in genetic mutations that cause breast cancer. So this is what we are trying to do. And this is a very busy slide. But the point I want to make is that we are not, we offer this blood test and we offer other blood tests as well. But we're in the business of trying to figure out which is the next car company, not the one who's selling us the slow, clunky car we have now, best car we have, but it's slow and clunky. But what are all the other tests coming down the pike? Is there a way for us to offer better AI-based screening of people at risk for lung cancer? Because remember, we've sorted people now into a high lung cancer risk group. What should that group get? What about people who are really looking for the best available technology to find early cancers? What other options do we have for them? So that's kind of the extent of what this center is designed to do. From a clinical point of view, what actually happens when you come in? So these are the kind of 6 components. We have a comprehensive consultation talking about research opportunities. We offer in the top in green these multi-cancer early detection tests. We have patients who can be navigated to standard of care screening. If you haven't had colonoscopy or mammogram or PSA testing or whatever else is appropriate, we can organize that as well. Genetic counseling when appropriate. If people are coming in because they have 10 family members with cancer and they can't get genetic testing performed, we can help them get that done. Specialized workup of positive results. So if you come in and you have a cancer test that's positive, we're a place that can get that workup done quickly. Integrative services. This is really interesting, and I didn't understand the importance of this up front. But as I walked through the example, there's 1,000 people who get the test, 10 are told they have cancer, and we can only find it in 4 of them. Those other 6 people are pretty terrified. And the anxiety and the stress of being told you probably have a cancer with this test, but we can't find it, that's a terrifying discussion to have. And so having integrative support services around that has become a really important part of the center. And finally, navigation to cancer providers. This team is not designed to care for a lung cancer if we find it. Their job is to find it quickly and immediately get you into a lung cancer clinic. We're very proud of our access to this clinic. So our average wait days to get a new patient in, it's 4 days if you're referred on a Thursday, we'll get you in on Monday. So it's a very efficient process. Again, we don't want a delay in this kind of clinical opportunity. This is more members of the team, our nurses, our nurse practitioners, our access team. This is our physician team. So our 2 leaders, Tara Sumarai focuses on ovarian cancer, but sees all sorts of patients in this clinic. Dr. Ernst focuses on lymphomas. Aparna Parikh focuses on GI cancers, breast cancer, melanoma, and then I can't see from an angle who the 4th is. Another GI cancer doc, sorry. Our social workers focus on lifestyle medicine, smoking cessation programs, psychosocial support. If you come to this clinic and you're still smoking, one of the most important things we can do, and the thing that we can take advantage of someone's time to do, is really offer tobacco cessation services. And again, we can get low-dose CT scan screening, colonoscopy, and mammography done easily. So I want to come back to the test for 1 second and summarize some of the things that I talked about. We don't know that this test offers a benefit to a population at this point. It might make people be less concerned, but if you say, Dr. Hochberg, prove to me that if I get this blood test, I will live longer, I can't do that. What I can tell you is that this is a glimpse into the future. My suspicion is that in 5 years, 10 years, everyone in the US will be offered this type of blood test on a yearly basis. Maybe if you smoke, it'll be every 6 months. Maybe if you've never smoked and there's no cancer in your family and your grandparents are alive in their 90s, you'll get it every 2 years because you're in a low-risk cohort. But I think this will be part of what we do in the future because this data will come out. Who should get tested? We don't really know. Right now, it's a personal decision. The company charges about $850, $900 for the test, so there's a monetary component as well. We think that we should start in people at the age of 50 and over, or people with an increased cancer risk. If you're a lifetime smoker, if you work in a coal mine, if you are a firefighter, if there's a significant history of cancer in your family, you should probably get it at a younger age. How often do we test? We don't know. What are the risks? The real risk is the false positives, the anxiety, the concern, but there is a risk around unnecessary biopsies. If the test is wrong and it says you have a cancer signal and we scan you and the scan finds a little nodule in your lung, that nodule has to come out. And even if that nodule's not cancer, it's just a piece of a powdered sugar donut you breathed in 5 years ago that made a scar, we got to take it out. And taking it out is a surgery. So there is that tiny risk around the edges of the workup of this. So this is our clinic. This is our website for our clinic. And we think it's a really interesting idea about how we are going to bring this concept of finding cancers at earlier stage forward. And you can get all this through the Vie team as well. So I wanted to spend the last 15 or 20 minutes, and I'm sorry that I'm being so long-winded on a late evening, talking about the way in which we think about multidisciplinary care, because it's really important. We think that there's exceptional care. You guys can get world-class care in Canada. You can get to a team that absolutely has world-class expertise in the delivery of standard of care treatments. But I want to talk about what I think the entire package of support looks like. So this is the way our system is organized. We have 190 medical oncologists. We have 60 oncologic surgeons across every area of surgery. We have 50 radiation oncologists specializing in every area of the body. And they're organized into these teams. A breast oncology team, this has 15 med oncs, 4 rad oncs, 6 surgeons, plastic surgeons. A breast evaluation team, trying to think about all the different ranges of people at concern for breast cancer, and so on. Each of these teams is responsible for conducting research. So overall, we have 1,200 clinical trials, often offering extremely innovative treatments for cancer years before they come to FDA approval, and then another year or two in general before the Canadian Authority gets them approved here. So I think that's one of the most exciting things for us, is that some of the advances that we've seen, we had CAR T-cell therapy available in clinical trials for patients with lymphoma and myeloma 4 years before they were clinically approved. And we were curing patients who otherwise really don't have therapy options. The other point I wanted to make, I made briefly before, about the fact that we are embedded in a general hospital. And that's really focused on the center column. I just saw a woman who's 28 years old, who's not married, who would like to be able to have children in the future, but now has been diagnosed with a lymphoma. And so I worked with our reproductive endocrine team to say, what can we do to preserve her fertility for the future? And we had a really complicated, nuanced discussion in front of the patient around how long can she wait for her cancer treatment? And if she waits 1 month, what's the chance of fertility? If she waits 2 months, what's the chance of fertility? And what is the cost in terms of cancer outcome? But the ability to have that conversation with a patient to understand the pros and cons of these choices, that's something that requires an in-person discussion with the patient in the room. And because I can pull on my colleagues in these disciplines, I can do that. So we have the same services in cardiology, nephrology, infectious disease, psychiatry, neurology, and rehabilitation. I want to give one more example. The third thing here is nephrology. So I took care of a patient who unfortunately had had a toxic exposure, and they'd gone into renal failure, and they were on dialysis. They were in their 40s, and they came to see me with a lymphoma. I can cure that lymphoma. The cure rate for that lymphoma is about 82, 83%, depending on how they tolerate the chemotherapy. But I didn't have any idea about how I was going to do that in a patient who was getting dialyzed every 2 days, where that chemotherapy would be pulled out of their system 2 days later. Their body wouldn't be exposed to it. So I sat down with Megan Seiss, our onconephrologist, and she sat in clinic, and we talked about the options for the patient and thought about how for that individual we could design a treatment algorithm that would preserve their chance of cure, not be too toxic because they didn't have kidneys, and also offer them success rate. So that's the kind of services we can put together in a general hospital. I promise I'm coming to a point here that makes some sense. These are other services that we offer, specialized services around lymphedema or immunotoxicity. We have a cancer primary care clinic. And then there are some specialty services around spine disease, brain metastases, or disease just in the liver. In addition, we have tried to recognize over the last 15 years that just giving the best chemotherapy into someone's vein does not take into account the entirety of what that patient needs. And patients have deep needs in many other domains. There are patients for whom their interaction with a chaplain who's available in our clinic as part of oncology care is one of the most important things we can offer them, a sense of recognition of their spirituality. There are patients for whom a healing garden and the presence of a healing environment and greenery and a place that they can walk and be outside that's just outside the walls of our infusion room is really important for them. I'm going to spend a lot of time in the example on the PACT team, this one called parenting. So PACT stands for Parenting at a Challenging Time. And the idea of this is that when a young person comes to see me, I saw a 37-year-old author who has a 5-year-old son. The parent's fear is divided between the fear for their personal experience and the fear for the impact of this on their child. And having a child psychiatrist who can sit with the parent and help them use the right language. The parent's goal is, of course, let's just keep everything completely normal. And that works okay for a 5-year-old, but think about your 10-year-olds and think about the piece of mail that comes to your house that says Cancer Center, or the text message they see when they pick up mom or dad's phone. And once a child of that age thinks that you're hiding something from them, they immediately assume the worst. And so the ability to help a parent provide age-specific graded information to children removes so much of that terror that a parent feels, not only going through the cancer themselves, but the impact it will have on their children and family. So how do we put this all together? So the patient's at the center, and we think that the best chance at the best case scenario comes from a combination of the best standard of care, the best experimental therapies, and the best supportive care. How does this work? I'm going to tell you a terrible story. A 36-year-old female smoker with 2 children, aged 9 and 6, finds a mole, and a biopsy confirms melanoma. And unfortunately, a CT scan shows a large liver mass. And she comes to see us. She comes in on a Wednesday. We have multidisciplinary melanoma clinic every day. And between noon and 1, each of the 8 or 9 cases, whatever it is that day, are presented. And we have a specific melanoma pathologist and a radiologist for every area of the body who reviews those cases with the team. And the 6 melanoma attendings, the melanoma surgeons and radiation oncology and social work sit around, and they briefly, really rapidly, sort of in a cohesive manner, talk about every case. And they decide, what does each person need? And so in this case, the decision is made that she needs to see a medical oncologist, a liver surgeon who's an oncologic liver surgeon, and a radiation oncologist. And they go in the room together, and they sit in the room with the patient and the family and talk about each component of the care. What does the medical oncologist offer? What are the options for surgery in this case? What are the options for radiation oncology? And the patient is exposed to the give and take between the specialists. Listen, we could think about a liver surgery, but that mass is right on the hepatic artery. That would be a huge surgery, and you might even get to the point where it removes enough of your liver function that you need a liver transplant, even if you survive this. So the way that we think about this is that each team is responsible for one component of the care. So in this case, the medical oncologist says, if we sequence a melanoma, and if we find a BRAF V600E mutation, which is present in melanoma as well as a number of other kinds of cancers, we have some targeted therapy options. Maybe she doesn't need chemotherapy. She's 36 years old. She absolutely needs genetic sequencing. How do we know she doesn't have an inherited mutation that will increase the cancer risk in her family? And the medical oncologist says, well, the standard of care for this is 2 immune therapy drugs that unleash the immune system, called nivolumab and relatlimab. And those together offer her about a 40% chance of being alive 5 years later. Not great, but for someone with metastatic disease, it represents some option. In the room, when they're talking about the case, one of the clinical investigators says, to the surgeon, if I could make this 20% smaller, could it be resected? And the surgeon says, yeah, you can get this thing to fall away from the hepatic artery and shrink in the right ways. Maybe I could resect this, and then we could talk to her about cure. And the clinical trialist says, listen, I have a clinical trial of a combination of an experimental immunotherapy drug with your existing drugs. It's a little more toxic, but maybe this offers a chance to take this unresectable cancer and make it so the surgeon can actually take it out safely. We tell the patient, we have another study trying to figure out how well chemotherapy is working. Let's measure little spilled DNA fragments from the melanoma in the blood. And if they drop really quickly, we think that's going to be a good sign. Let's put her on that trial as well. The social worker in the room says, you guys aren't thinking about this completely. She's 36 years old. She's going to go through intensive treatment. She has 2 young kids. This is going to be impossible on her husband and on the rest of the family. What we need to do for this person is, in addition to these experimental therapies, we should put her on a palliative care supported clinical trial, which offers additional resources in the home to the caregiver trying to see what the impact is on the entire family of having additional home health aides go in these really challenging situations to support the husband. Finally, we think about the supportive care components. A genetic counselor to talk to her about the results of that testing, help her understand the impact on her family. This is a prime example, sorry, this is really loud, where the Parenting in Challenging Times team is essential. How are a 9-year-old and a 6-year-old going to think about what mom's going to go through? How are they going to think about it differently? Can you begin to speak to them about the chances for success if the clinical trial works? There's no way the 6-year-old gets that, but maybe you can begin to explain bits of that to the 9-year-old and the hope that the family would have. And finally, she's a smoker. Let's have her sit down with the smoking cessation team while she's here. At least we can cross that off of her list. During treatment, she feels sick, and so we pull in a massage team as well, integrative therapy, and ensure that she feels supported during her treatment. So the idea about this is that it may be that ultimately she doesn't want to go on the clinical trial. It's too many visits back and forth to the hospital, and what she's offered is standard of care with nivolumab and relatlimab, and she doesn't become resectable. But we've thought comprehensively around who she is as a person. What's the best standard of care treatment we can offer her? What's the best experimental therapies we can offer her? What's the best supportive care? What offers her the best chance at the best case scenario? It's a terrible story, but I think it gives you a sense of how we think about cancer care. And each of our 19 groups do that same thing. So I wanted to close with a couple of points for you to remember. I think the points to think about are that we need to think about cancer care differently. We need to think about being proactive around the detection of cancer in the way that we are proactive, and your team here is proactive about all the other components of your health. We're beginning to get the technology to think about how we can detect cancer early. Once you divide people into those groups of low risk, medium risk, and high risk, and you begin to apply those early detection tools to each of those groups differentially, we think we'll be able to push back the mortality risk of cancer. Thank you again. Okay.